afternoon, everyone. I am Dr. Abhishek. I again extend a warm welcome to you all present here. So I'll be going through a few interesting cases, and I'll be requesting our panelists and national faculty to provide their valuable insights in the cases. So my first case is a 66-year-old elderly gentleman who came with a history of left eye cataract surgery done in July 2023. He presented to us in December 2023. Best corrected visual acuity in the right eye was 20/30, left eye 20/40. Intraocular pressure was 12 in the right eye and 28 in the left eye, and the patient was already on maximum medical therapy. On slit lamp examination, the anterior chamber in the left eye showed pigments on the endothelium with foldable IOL noted in the sulcus. Right eye gonioscopy, there was open angles with grade 1 to grade 2 pigmentation. However, left eye gonioscopy image, as shown here, had increased trabecular meshwork pigmentation, grade 3 to grade 4 pigmentation. Our right eye disc showed a 0.5 cup disc ratio with superior excavation, and left eye had a 0.7 cup disc ratio with a localized inferior notch and associated retinal nerve fiber layer defect. Right eye's fields 24-2 showed few non-central scotomas and depressed points nasally. Left eye had a typical superior incomplete arcuate scotoma repeatable on 10-2. So my question to the panelists are, what could be the causes of raised intraocular pressure in the left eye?
The patient is not on steroids right now, right?
Patient is currently not on steroids. Patient is on only AGM and...
Okay, fine. So this is a clear-cut case of a UGH type of a picture. So a lens in sulcus, hydrophobic, you said Alcon IQ. So it's not a good thing to be in the sulcus, and the pigment dispersion that has ensued has caused a secondary open angle type of a picture, and that has led to this ocular hypertension and obviously the glaucoma. So in this case, the raised IOP is definitely the pigment release that has clogged the meshwork. You can see that on gonioscopy. And the next step, so you have the patient who's at 66-year-old already on maximum medical therapy with a field loss. And the only option here is he has to undergo a surgery to bring down the intraocular pressure. Now it has two aspects to it, whether you will explant the lens or you'll keep the lens behind. So considering that he's an established glaucoma, there are two schools of thought. People say leave the lens behind and treat the glaucoma. But I would put it in a slightly different way. What I like to do is, I see whether the posterior capsule is intact or not. Because the primary reason is the lens, and if this is the material accuracy of IQ, it will often erode from the iris into the anterior chamber, causing dysphotopsia also. Besides, if I do anti-glaucoma surgery, which is most possibly a trabeculectomy in this case, what happens is the subsequent pigment release and inflammation will affect the long-term success of a trab. So if I have a posterior capsule intact and a lens like an IQ, which I can explant very easily, then I would also explant the lens in addition to doing a trabeculectomy. The cases in point for this are that this particular lens, I have had sufficient experience in which the lenses had been left behind because the PC was not intact, and patients have landed into vitreous hemorrhage, leading to a failure of the filter. So these are the important considerations that are there. So in my case, I would definitely try and explant and also do a anti-glaucoma surgery for this case.
Very true, Dr. Sachin. I totally agree with your thought process, and you have already answered my second question. So I would like to ask Dr. Sunil, what can be the telltale signs in early diagnosis in such cases?
So this being a secondary glaucoma, and secondary glaucomas are almost always unilateral because there's some cause behind it, unless it's a systemic disease which is causing a bilateral condition. And as Nandini had showed that secondary glaucomas, you have to know what the cause is. In addition, I think some amount of history taking might just help me, because it could be that the patient has had trauma in the past, which could be causing a unilateral glaucoma, manifest now, or probably it was missed earlier. There could be, if the patient is a diabetic, I would in addition look at the pupillary margins, whether some rubeosis is developing, because when I start examining, now that you've told me all the findings, that's a different thing. But when a patient comes to me, I would try looking at the clinical signs for a unilateral case of a secondary glaucoma. So whether any rubeosis is there which has started and which was missed earlier before the cataract surgery. And obviously once you've dilated and you've realized that it's your lens which is causing, and you proved it because there's a lot of pigmentation in the angle. So then you know it's a lens which is causing the thing. Apart from that, Whether he was on chronic steroid therapy, which you ruled out already.
Yes.
I think that's all. I mean, maybe you would for medical legal purposes, you have to do a UBM to try to prove it through the patient that probably the lens is in the sulcus, and that could be one of the causes leading to glaucoma. So that would be one additional thing I would advise with the from medical legal point of view.
Okay. Thank you, Dr. Sunil. So very comprehensively you explained the importance of taking a good history in such patients, a very thorough, comprehensive examination of the patient and documentation, which is very important.
Just one question I have. So it is very evident from the discussion that here the lens is placed in the sulcus. So like in your experience, have you seen cases even on placing in the bag? Has it caused any time secondary glaucoma like this?
So if the lens is in the bag, so again, that's what it comes to your history, past history, any injury, any...
Say it's an uneventful surgery, like the lens is placed in the bag, but still I see that there's pigment dispersion or the pigments are on the endothelium and the TM shows that there is increased pigmentation.
So whenever you are saying in the bag, I presume is the optic and the haptic both in the bag?
Yeah.
Within the rexis margin?
Yeah. Can it happen? Is there a possibility is my question. Like,
with the optic margins inside the bag within the rexis, I have not seen yet.
Okay.
No, lens could not be the cause. There could be an associated condition, like pseudo exfoliation, which could be there. Unilateral.
Ruling out everything, like assume that his...
Not due to the lens.
Okay.
Yeah, so I think what Sachin mentioned is very important. You can have a lens in the bag, but if your anterior rexis margin is not completely covering the entire optic margin, then you can have pigment dispersion as well.
So say a large
eccentric rexis,
okay.
you can have when the capsule fibrosis, one edge of the lens can be lifted up and that can rub on the posterior surface of the iris. So that can cause it. So one point I would like to add, I totally agree with whatever was discussed until now, but one point I would remember is, I would like everybody to remember, and for me specifically, I would not go and tell this patient that it is only lens related. It may be lens related, but patient is predisposed. Even if you look at the contralateral eye, the optic disc shows some changes. They are not glaucomatous, but the disc and the cupping, they don't look normal. So generally also, if you see, even when we go and look at the secondary glaucomas, whether it is steroid-induced glaucoma or post-cataract surgery, complicated glaucomas or traumatic glaucoma also for that matter, there are people who are predisposed to glaucoma, primary glaucoma, but there is an event that has precipitated and that has caused a secondary glaucoma in this eye. So you should always try and watch this patient, even for the contralateral eye. I would follow up this patient.
Thank you very much, Dr. Sirisha, for your inputs. So we'll come to second case, a 34-year-old young male who came with a diagnosis of right eye retinal detachment. He was pseudophakic in the right eye. He underwent VR surgery in the same eye in April 2024. After 3 weeks, the IOP in the operated eye was noted to be 40 millimeters of mercury. Patient was started on anti-glaucoma medication. On slit lamp examination, what was noted was a pupillary block with iris Bombay. So right eye yak peripheral iridotomy was planned. Patient underwent the same. There was minimal hyphema noted on the same day with the deepening of the anterior chamber and resolving of the iris Bombay. IOP was again under control post-PI. At 1 week, the hyphema cleared and IOP remained under control. My question in this case is there a role of surgical PI in pseudophakic and phakic eyes?
Okay, so one thing is that you have to remember is that whatever said and done, silicone oil is a very pro-inflammatory agent. So over a long period of time, if you followed up silicone oil filled eyes, who unfortunately have the oil has not been removed for various reasons, you will have some amount of subclinical inflammation that is smoldering inside the eye. So this is a clear-cut case of iris Bombay. So you can have a steroid response in these cases. You can have overfills in silicone oil eyes. You can have pupillary blocks which happened here. Or it can be a pre-existing glaucoma which has been worsened because these are unfortunately myopic eyes in this cohort. So the role of surgical PI, absolutely I would be in favor of doing a PI for 2 reasons. One, because we know that late onset glaucomas have an inflammatory component. And secondly, if you do a laser PI in these eyes afterwards, then in this case the incidence of closure is very high. So laser PIs close very fast. Even if you do multiple PIs will close fast. Sometimes you have to do them repeatedly in case you have not done before. And secondly, you can't get a big LPI as much as you can get a basal iridectomy when you do it at the surgical time. And with the current armamentarium, I think doing a small surgical PI with a vitrectomy cutter is very easy. for our retina colleagues or even for us. So I think inferior or inferior-temporal, infranasal, a small PI would ideally should be in place if you're doing especially in those eyes where you think that the silicone oil will stay in for more time.
In this case, like there are many cases where they put silicone oil and not all go into pupillary block like this. So do we look out into any conditions why there was so much inflammation causing 360-degree posterior synechia, or should we rule out anything else?
So patient having some pre-existing uveitis, which is again manifested. Patients stop putting prednisone on the Predfort drops, which has again resulted in inflammation resulting it. And obviously if the iridectomy was not done on table, which could be, because usually silicone oil, they need to do an iridectomy.
Are there any VIA surgeons, what is their take on doing PI in phakic and pseudophakic? I assume that without saying they do in aphakic eyes, but what about in phakic and pseudophakic eyes when the silicone oil is injected?
As you said, then
Use the mic.
if there is a posterior capsular dehiscence PCR or in aphakic eyes, the PI is a must. But in phakic eyes, I don't think so. We do any PI. And iridectomy is done
In pseudophakic and in
with
phakic.
pseudophakic with a posterior
So,
capsular dehiscence or rent, or in aphakic eyes, we do a inferior PI for silicone oil filled
So
growths.
pseudophakics with intact PC, and in phakics there is no indication to do.
This patient you said had after 20 days of VIA surgery, iris Bombay, right?
Yes, yes, doctor.
So probably one of the cause could be there is an inferior detachment, because when you have filled the eye with silicone oil and it's not an overfill, at the end of surgery retina remains attached, and after 20 days, 30 days it occurs, there could be inferior detachment which is occurring, and that's why there is inflammation and all these things happening. Again, as Chintan said, in a pseudophakic eye with intact posterior capsule and PCL, we never do inferior PI because it's not necessary. There has to be something from behind pushing it in front.
So very nice point as said.
Yeah.
Finding
So-
out the cause is very important for Dr. Sirisha.
Yeah, so I think, I mean, just for the benefit of the other, everybody to take home the message that in a pseudophakic eye with an intact posterior capsule, and if it is a clean vitreoretinal, when I say clean vitreoretinal surgery, it was a rhegmatogenous retinal detachment, operated, everything else is okay, then it's not a routine to do a surgical iridectomy. And in a phakic eye, a routine surgical iridectomy is not performed. In an eye which is a phakic, or a situation where there is a dehiscence of the posterior capsule or a complex prior surgery, or there is an inflammatory condition prior, then a surgical iridectomy would be indicated, right? Yeah, I think it's very, very important, because let's say if it is a pseudophakic eye with a complex cataract surgery that the patient underwent and had a cortical matter drop or a nucleus matter drop, and somebody goes and does a vitreoretinal surgery for that and may or may not have had an RD along with it. So there is a pre-existing chance of inflammation, or there is some ongoing inflammation in that particular eye. In situations like that, I think surgical iridectomy would be necessary. Otherwise, we see this PI blocking again and again and again multiple times, and we may even have to go and do a surgical iridectomy in them. So it becomes important to possibly preempt and then do a surgical iridectomy in those eyes.
So there are two things. One, obviously, when the eye is a phakic eye, you do not expect a transzonular migration that easily. First, we are talking here about pupillary blocks most of the time. But when you are considering pseudophakic eyes, transzonular migration does take place, number one. And number two, the pro-inflammatory mediator migration also is more. So the amount of, and secondly, one thing is we have to remember is the silicone oils that are available are of different purity and different density. And we've seen a spectrum of intraocular inflammation that occurs after silicone oil usage. I think all my retina colleagues will also agree. Depending upon the pre-existing inflammation inside the eye, the kind of surgery that has been done. So it's always important to judge, but for a pseudophakic and for a aphakic, definitely my choice to do a iridectomy on table. That's very safe.
I think we need to move on. There are more sessions. Let's go to the next.
So moving on to third case. Third case is a 22-year-old male who was suspected for glaucoma and came for a second opinion. Both eye best corrected visual acuity was 20/20 N6. Intraocular pressure was 15 millimeters of mercury in both eye. Fundus showed both eye disc around 0.6, 0.7 cup disc ratio with superior rim thinning. We went ahead and performed fields where both the fields 24-2 showed depressed points in the inferior quadrant. 10-2 was essentially normal in both the eyes.
So there is the nerve fiber layer loss and the field defect that you see is not glaucoma. The nerve fiber layer loss is directly at 12 o'clock position. The field defect is not an arcuate field defect. This is a condition called superior segmental optic nerve hypoplasia. It's a stationary condition, congenital. We don't need to investigate him for glaucoma. You can reassure him. Nothing is needed.